Good afternoon and Happy New Year. The title of my presentation today is The Devil is in the Differential. Patient-Centered Care, One Clinician's Viewpoint. This title requires a little bit of explanation. As many of you might know, I closed a full-time primary care practice, family practice, insurance-based at the end of last year. At that time, my intention was to start to look more closely at all this data that I had accumulated over 10 years of doing concurrent CIRS work and start to really focus on some research that is needed to better define things for us. When Scott and I originally talked about my presenting today, the plan was for me to give a preview of the science and the research that was going to be presented in May at the conference in Texas. So as I started to do this preview and put it together, larger issues evolved that I think are so pertinent to the CIRS community, surviving mold, that I expanded the concepts a bit to include those questions. So this presentation will present more questions than answers, but they're important questions in moving our surviving mold community forward in a patient-centered way. So the research that I'm planning to do and present the results of in May starts to look at other issues that are concurrent in the CIRS patient. So looking at things like histamine, looking at menopausal status, looking at thyroid. And trying to make associations with regulatory hormones like MSH or VIP. So the plan is to do some fairly sophisticated multivariate analysis on these issues to start the process of identifying where we then can focus more specific research. But the issue that I raised today in terms of the differential speaks to the complexity of the patients that we serve and how do we provide patient-centered care, I guess, as opposed to clinician-centered care. Clinician-centered care would be, this is what I do, and I don't see the other things. So it's up to you, the patient, to figure it out. Patient-centered care would be that the CIRS specialist is a partner with that patient and can help them navigate what they need to do to get these other situations evaluated and treated. I have no financial disclosures to make. I am a certified family nurse practitioner and I have been for 29 years. I had a full-time insurance-based independent primary care practice, Rockingham Family Healthcare, for 26 years. I learned a lot from patients and I had a wonderful experience doing it. But the work of doing primary care, in addition to CIRS work, the demands were far too great personally. And so I did give up the practice at the end of last year. I've been shoemaker certified for 10 years. For the past 5 years, I've been a member of the Legislative Commission to study environmentally triggered chronic disease in New Hampshire. I represent the New Hampshire Nurse Practitioner Association on that commission, and I am the chair of the Education Subcommittee. As that chair, I organize presentations for professionals, clinicians, physicians, nurse practitioners, We put together a group of presenters that include Dr. Jonathan Patali, who's the state toxicologist in environmental services. Dr. Megan Romano is a Dartmouth epidemiologist who is an expert in PFAS chemical contamination, and a state legislator from a community that was severely impacted by PFAS chemical contamination and has seen renal cancer rates 3 times what the national average is. We don't only look at PFAS chemicals in that commission, we also look at heavy metals, arsenic, lead. We look at cyanobacteria, New Hampshire, a lot of water and a lot of cyanobacteria present and a lot of cyanotoxin. So what you'll hear from me largely is a wider view of contaminants. And I bring that to you for consideration because our patients often have these other things as well. And I'm the founder of the Northeast Environmental Illness Alliance, which is an informal group of clinicians, all different types, who look at issues related to environmental contaminants. Primarily, CIRS was the focus of this group in the beginning and still is. And it's a way for me to update non-surviving mold clinicians about changes within the protocols so that they can follow what is the most recent changes. So, first fact, the Shoemaker protocol requires a differential diagnosis in determining that CIRS is the root cause of symptoms. Well, if I'm in primary care working up a complaint of chest pain, I have one symptom. I still have a fairly lengthy list of potentials, right? It can be the most benign being chest wall pain, could be heartburn, GERD. The more severe potentials, the things at the top of the differential list, pulmonary emboli, atherosclerotic heart disease. But I have a finite list for this one symptom. So what happens when in CIRS when there are so many symptoms and there are many conditions that people are already diagnosed with, and then some that they haven't been diagnosed with that are potentially present in that patient. And on top of that, now we add on the cascade of additional problems that CIRS triggers. So what happens with those? What does the CIRS specialist do? What is their responsibility for patient-centered care to look at those symptoms and potentially look at referral for evaluation and treatment for those conditions? So what are some common diagnoses that our patients with CIRS arrive with? Well, many of them arrive with a thyroid condition, and this is one of the areas I intend to try to fine-tune the situation a little bit better, is the incidence of hypothyroidism by itself or autoimmune thyroiditis greater in the CIRS population than it is in the general population? We don't know, but it's a good question. And some of our patients come to us already diagnosed with hypothyroidism, but we don't really know if they haven't been worked up recently, whether or not they actually have that condition. So if fatigue is on their symptom list, it can be from CIRS, it can be from proliferative physiology, certainly can be. However, it also can be from an undiagnosed thyroid condition. What is the CIRS specialist responsibility? It's not part of our routine for the protocol. Just a question. what is the responsibility to patient-centered care if you don't know whether or not they have a thyroid condition? We certainly know that diarrhea is on the symptom list for CIRS. A person can have inflammatory bowel disease. They could have simply overexpression of histamine causing diarrhea. They could have irritable bowel disease. They could have small intestine bacterial overgrowth or SIBO. Lots of things they could have that's causing that diarrhea. One of the things that I put into practice early on that I find helpful in trying to sift out whether or not patients have some of these other conditions is at each follow-up, when I do the review of symptoms, I'm particularly interested in those symptoms that have not changed at all with treatment of CIRS. Because the expectation is that with treatment for CIRS, any associated symptoms will change. Sometimes the symptom will get worse in the short term as a detox reaction, and sometimes it simply gets better. But the expectation is that symptoms improve. So what happens when a symptom doesn't change? So you have, for example, a person who has knee pain. The knee pain doesn't change. It stays the same. Well, the person could clearly have degenerative joint disease, right? So what is the responsibility to the patient in a patient-centered situation when the symptom doesn't change, not connected to CIRS, but clearly warrants further workup? Tick-borne infections are a quagmire. I mean, we have very inadequate testing available. Tick-borne infections are prevalent and widespread, and it becomes incredibly challenging in diagnosing, in looking at risk, and certainly in treating at times. So what does the CIRS specialist do to try to identify whether or not there's a concurrent tick-borne infection here, or whether or not there isn't? Heavy metal toxicity, I mentioned. This is an area that I've always taken time and effort in my primary care practice, as well as my CIRS population, in looking at the 5 more common metals in real-time LabCorp and Quest testing to see if they have elevated current exposure. I'm not testing necessarily for remote exposures, only interested for the moment in, does this person have a current high exposure? Because quite honestly, aluminum and arsenic are very commonly elevated. And arsenic is both a carcinogen and an inflammagen. In New Hampshire, for example, we have the highest per capita rate of bladder cancer in the country. And bladder cancer is associated with arsenic. And so one of the reasons the commission that I sit on looks at that situation very closely. The gentleman I had from Massachusetts come in as a new patient about 6 months ago had an arsenic level of 28. Unbeknownst to him, except he did notice those funny lines on his fingernails. These are called Mies lines, and he had them, and they are associated with arsenic toxicity. So for him, it was a good thing. He has memory impairment. He has all of those cognitive symptoms that we have on our symptom cluster. He does have CIRS, but certainly high arsenic was not helping him either. So we have these different situations, some diagnosed, some not diagnosed, but possible that our surviving Mo community needs help understanding what their role is and how they should be approaching these things. So how do other specialists manage multiple diagnoses? So if the dermatologist is treating the patient for psoriasis and identifies some skin sequelae consistent with lupus, the dermatologist is not going to work them up for lupus. The dermatologist is going to refer them back to primary care or refer them to rheumatology if there is no primary care. If the orthopedist, whose patient with degenerative joint disease comes in with a knee effusion, and they tap that knee, which they will typically do, and if they do that in the Northeast, I don't know about other parts of the country, they will PCR test that fluid for Borrelia. So what happens when the aspirate comes back positive for Lyme disease? The orthopedist is not going to treat the Lyme disease. The orthopedist is going to refer. And likewise, if an ophthalmologist is treating the patient for glaucoma and on exam finds a retinal emboli, they're not going to do a coagulation workup. They are going to refer that patient. So what does the CIRS specialist do when faced with other conditions that require evaluation and treatment? This is the question. And then, just to add to the issue, we have a cascade of potential other diagnoses that are downstream issues concurrent with the CIRS diagnosis. An important point I want to make here before moving on, this population that we treat has often been so traumatized by their experience in the medical community that often they've either stopped their relationship with primary care or actively avoid other clinicians, which poses an even greater problem for the CIRS expert, who would ordinarily say, you might have this, say, thyroid condition. I think you should speak to your primary care about getting some thyroid testing done. You have fatigue. That's a legitimate reason to do that. But so often, at least in my population of CIRS patients, they actively avoid primary care situations, so you don't have that person to refer to. So the question again, what does the CIRS expert do when faced with a situation where there is no primary care to have these other things worked up? But now we have these downstream conditions. These are very specialized conditions. Postural orthostatic tachycardia syndrome, POTS, very common. Now, sometimes these things improve simply with treatment of CIRS. Or they improve, say, POTS, you just add in some sea salt and minerals, and you can stabilize that patient and their symptoms. But many times they need someone who is expert in treating POTS. So what does the CIRS clinician do when their patient says they stand up and they have near faint experiences and the minerals and the saline have not helped them? Do you not do anything and risk that one of those times they're going to stand up and they're going to have a fainting, a syncopal episode, and now you have a head injury on your hands as well? People need to know how to proceed with these when these concurrent diagnoses are present. Mast cell activation syndrome, or simply histamine dysregulation, upregulation of histamine genes, commonly present. Now, in some situations, this histamine dysregulation corrects with the treatment of the CIRS, but certainly not in the majority that I see, and certainly not in the research to date that Dr. Shoemaker has found, looking at genies, that the gene upregulation in the histamine genes persists after CIRS is corrected. So what happens when someone is dramatically overexpressing histamine? It is creating gut issues. It's creating certainly persistent brain inflammation. What does the CIRS expert do in that situation? Dysautonomia, common, complicated situation. Certainly, CIRS experts cannot be expected to be expert in all of these, but you certainly need to know what the signs and symptoms of these conditions are. Maybe have a few basic evaluative techniques to use. So for hypermobility syndrome, there are some really basic things you can ask the patient to do. Even with a remote visit, you can ask them to do certain things, and that will give you information about risk, not diagnosing them, but if those markers are present, then you certainly are legitimately able to say you should be seeing an expert in Ehlers-Danlos syndrome. I mentioned some of the others. The EM, Dr. Sparks, was quite clear in her presentation for those of you who heard it. And she was clear in that she said, the earlier this is picked up, the better it is for the patient. So that burning pain, that burning person syndrome, even when it's early and subtle, very important for the CIRS clinician to be able to identify the potential of. So in conclusion, more questions. Sorry. But how can CIRS specialists, how can the surviving mold community of CIRS specialists who are so good and the best at doing what they do approach the concept of patient-centered care so that we can be the most comprehensive in terms of making sure the patients get what they need? As a group, can we help each other to learn about these things? Sure, we certainly could. We could have educational programs within the group that would define for us, for the group, how do you know risk for each of these conditions. But then we have this even greater challenge of who to refer to. And that is going to be a huge undertaking, because certainly we want to refer to people who do the right kind of care. When you look at tick-borne illness, there's a lot of people that diagnose and treat tick-borne illness. There's a small minority of them that we would probably be comfortable referring to. So, but that doesn't mean it's so great a challenge that we can't undertake a conversation about it. So, possibilities would be the group decides that maybe we need to have a subcommittee, some kind of small group to work through some of these questions and to propose some kind of action plan for patient-centered care. I thank you for your attention. I look forward to a lot of discussion about this arena, and I hope that we can move the expert surviving mold community in CIRS forward with being the best at patient-centered care as well. Thank you very much for your attention.